afternoon, everyone. Thank you for joining us for today's webinar. My name is Taeyang Jung. For those who do not know me, I am the Events and Project Coordinator at Family Councils Ontario. Today's webinar will be on end-of-life options in long-term care, and this event is co-hosted by Family Councils Ontario and Dying with Dignity. This is the second of 3 events we are collaborating on. Next Wednesday, on March 13th, we have our last event on medical assistance in dying. If you are interested in attending the final event, you can still register using the same sign-up link that you used for this webinar. If you have already registered, you will get a Zoom invitation from me shortly. Before we start, I would like to take a moment to recognize the land on which we are gathered today. We are meeting on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. Just a few logistics and housekeeping rules before we turn things over to our guest speaker. First, you'll notice that everyone is in listen-only mode. We have reserved time at the end for an interactive question and answer period. At the time, we invite you to use the Q&A box to ask your questions to our guest speakers. And you can also use the Q&A box throughout the presentation to put your questions there, and we will address them at the end. And please only use the chat feature for any questions regarding technical elements, if you have any issues. So Q&A box for questions regarding presentation, and chat box for technical questions. For your information, today's session will be recorded and will be available to participants and also those who are not able to attend on Family Council Ontario's website and our YouTube channel. Now it's my pleasure to introduce you to our speakers for today's webinar. We have Peter McCulley and Barbara Bresford to our webinar today. Peter McCulley is a member of the Education and Community Outreach Committee of the Toronto chapter of Dying with Dignity. He has been a board member at the Dorothy Lay Hospice in Etobicoke since 2014, including a 3-year term as the chair of the board. He believes that education can have a positive impact on the quality of a person's death and lives of the family members they leave behind. Next, we have psychologist Barbara Bresper, who has followed her interest in bereavement and grief after 40 years in private practice. She has acted as a witness for those requesting medical assistance in dying and is on the executive of the GTA chapter of Dying with Dignity Canada, where she works with people exploring their advanced care plans. Now, I will pass the mic to Peter for his presentation.
Thanks, Taeyang. I will share my screen here. Okay. In our grandparents' generation, people got old and they got sick and they died. And in our generation, people get old and they get sick and they get treatment options. The received wisdom from our ancestors is not sufficient to guide us as we deal with the multiplicity of medical options that are now available to us. So today's presentation will provide an overview of end-of-life options in Ontario. The information included in today's session, end-of-life options in Ontario, is timely and accurate as of today, being March 6, 2024. If you're watching a recorded version at a later date, please note that subsequent changes to relevant legislation or regulation may affect the accuracy of the contents. Our goal today is to talk about end-of-life options for care, make them a little easier to understand and less overwhelming, and provide you with some resources for your own planning process. If you talk to people about the death of a parent, they will often say, if we in our family had known then what we know now, our family would have handled things differently. So with that in mind, this presentation will point out some options and some decision points that are not always obvious in the moment. So this is the agenda for today, and it will be in 2 parts. I'll speak to the first 4 options, the first 4 agenda items, and that will take me about half an hour. And then we'll have half an hour for a question and answer period, and my colleague Barbara Bresver will take the lead on the question and answer period. So if you put any questions you have in the chat, that would be great. And we can also hear from you during the live question and answer period. A little bit about Dying with Dignity. We are a national human rights charity committed to improving the quality of dying, protecting end-of-life rights, and helping people across Canada avoid unwanted suffering. We do this through advocacy, support, and education. You may have heard of Dying with Dignity because they've been very involved in putting MAID legislation in place, medical assistance in dying legislation in place in Canada in 2016, and they've been very involved in subsequent amendments to that legislation. At the local level, the local chapters have a mandate for outreach and education. And as part of the Toronto chapter, I'm part of the community and outreach arm of Dying with Dignity. And so I'm here talking to you today. This is a roadmap for what I'm going to talk to you about today. So if you start on the left, conventional medical care, that's what many of us receive during our childhood and our adult life. But as people approach end of life, their care options actually broaden out. And I'm going to talk a little bit about conventional medical care, hospice palliative care, medical assistance in dying, and some other end-of-life options. So the real focus of this presentation is to help people understand the options and allow people to make informed choices. The second thing that you will see here is across the bottom, there's a green arrow called advanced care planning. And last week, you heard more about advanced care planning. I will touch on it briefly in this presentation, but there was a more detailed presentation last week, and I believe that a recording of that presentation is available if you would like to see it. So let's talk a little bit about conventional medical care. We're all familiar with it. We go see our family doctor, we go to the hospital, and the process is usually diagnosis, treatment options, and then treatment. At end of life, it's important to ask about and explore all of the treatment options and to make sure you understand the side effects and the consequences. Often, in an effort to be optimistic, doctors and nurses don't talk a lot about the negative side effects or the negative implications of a procedure on someone's quality of life going forward. So it's important to ask a lot of questions. Here's an example of what I mean. For people that are on kidney dialysis, meaning their kidneys don't filter their blood properly, so they sit beside a machine and their blood goes out and gets filtered by the machine and then comes back to their body. The national average is that about 60% of those people will die in the next 5 years. And in 2019, there was a survey done of people that were on kidney dialysis, and they were asked if they expected to die in the next 5 years. Only 11% of the people on kidney dialysis expected to die in the next 5 years, but the national average was 60%. So my point here is it's difficult to make good decisions if you don't have good information. So it's important to ask the questions, and that will lead to better information and allow you to make better decisions. The next end-of-life option I'd like to talk about is palliative care. Palliative care is care that does not hasten death and does not prolong life. It focuses on the quality of life for the patient, making the most of the time that they have. It focuses on the patient and their family. And family is defined as whoever is important to the patient. Palliative care doctors and nurses have enormous expertise in pain and symptom management, and they do a great job of helping people manage their pain if they have it or their symptoms as they approach end of life. And palliative care focuses on family relationships and the psychosocial and spiritual side of life, and goes beyond the death of the individual to include bereavement and grief support. People receive palliative care in many places. They often receive it in their home. There are residential hospices in Toronto and around where people can receive palliative care. And increasingly hospitals are setting up palliative care units. Let me just drill down for a minute on the residential hospice care. What happens is, as an individual approaches end of life, the burden of caregiving generally falls on the family members. And as the person gets closer to their end of life, the burden on the caregivers goes up, and it can be really a huge burden. So some individuals choose to go into a residential hospice. And what happens is that the burden of caregiving is then shifted to the staff at the hospice. And what that means is that the family members get to go back to being family members. They get to go back to being a wife or a husband or a son or a daughter. And many families say that having that window of time where they've been able to hand off the caregiving burden and simply function as family members, having that window of time has been enormously helpful for the family. Another way to understand palliative care is to contrast it with conventional medical care. In his book, Being Mortal, Atul Gawande, the author, talks about the objective of conventional medical care being to cure the patient, whereas palliative care focuses on caring for the patient in a holistic way. So he uses the language of care for me versus cure me. And at end of life, some people choose to focus on being cared for as opposed to focused on being cured. Another difference is that conventional medical care tends to focus on the patient, whereas hospice palliative care tends to focus on the patient and their family, so it's a broader scope. And the scope of palliative care also goes beyond that of conventional medicine, in that conventional medicine tends to focus on either surgery or medication, and palliative care deals with psychosocial and spiritual needs. At end of life, people often ask the big questions. What was the meaning of my life? What will my legacy be? Are there issues or relationships in my family that I need to pay attention to? And palliative care, people journey with an individual as they wrestle with these bigger issues. And here's a life hack. Some families have found that asking to have a palliative care physician added to the care team can be very helpful. So usually there's the family doctor, and it might be the cancer doctor or the kidney doctor or the lung doctor, or whoever is part of the medical care team, but families can ask to have a palliative care physician added to that team. And palliative care physicians help people at end of life every day. That's what they do. So they're very knowledgeable. They're comfortable talking about it. They have very good information to share. And they can also talk doctor to doctor to the other members of the care team. So they bring the perspective of caring for the individual, where most of the other professionals are very focused on curing the individual. And that can be a very useful dynamic. And so many families find that it's helpful to ask that they have a palliative care physician added to their care team. And as a bonus, palliative care physicians often make house calls. So medical assistance in dying, this is the formal definition. The administration of a substance by a medical nurse practitioner at the person's request that causes death, or prescription or providing a substance to a person on request for self-administration to cause their death. This is often referred to as MAID. And there is a presentation next week that will go into more detail on this, so that I will give you some information, and if you'd like more, certainly tune in next week. Medical assistance dying was made legal in Canada in 2016. And to put things in perspective, since then, there have been about 45,000 deaths in Canada by MAID. It's a highly regulated process. And by that, I mean that the individual must voluntarily apply for MAID. 2 independent assessors must each determine if the person qualifies. And then at the time of the procedure, the individual must again provide their consent. So basically, an individual can opt out of the process at any time. They can stop the process at any time. And on the roadmap slide, when I showed you the green circles, all of the green circles overlap. They're not silos. There's a lot of overlap between them. And this is an example where in 2021, over 80% of the people that received MAID had also received palliative care. So people often receive different kinds of treatment, sometimes at the same time, sometimes sequentially. These are other end-of-life options, and I'll talk a little bit about each one of them in turn. Voluntary stopping of care. People who wish to allow their lives to end naturally sometimes refuse or discontinue care, and that includes healthcare to prevent or cure an illness. It may be referred to as voluntary stopping of care and can involve stopping oral food or drink, respiratory support such as oxygen, or antibiotics. My friend Charlie, his father was in a home and his father had severe dementia. And Charlie and his brothers would go and visit their dad every week, but it was heartbreaking for them because their dad didn't know who he was, he didn't know where he was, and he didn't recognize his sons when they came to visit him. It was also heartbreaking because their father had been very clear with them that he didn't want to end up in this condition. Sometimes Charlie's dad got a bladder infection, and the medical team would give him antibiotics, and that would clear up the bladder infection. And so at one point, Charlie asked the doctor, he said, "What happens if my dad doesn't get antibiotics for his bladder infection?" And the doctor said, "Well, your dad will die." And this is an example of where the options are not always immediately obvious. So for the medical team, it was simple. Bladder infection, antibiotics, move on to the next patient. But for the family member, this was a fork in the road. This was a decision they had to make because Charlie and his brothers knew their dad didn't want to be in this circumstance. They knew that they had authority to make medical decisions on his behalf. And so they spoke amongst themselves, and then they went back to the medical team and said, the next time our dad gets a bladder infection, don't give him antibiotics. And in due course, their dad got an bladder infection and he died. So for me, the takeaway is it's really important to understand your options, and they're not always obvious. In Canada, nutrition and hydration by tube are considered medical treatments. You have the right to refuse them or stop them if they've started. Voluntary stopping of eating and drinking is not something people undertake lightly, and they generally undertake it with a doctor's supervision. Switzerland. Why are we talking about Switzerland? Well, it's the only country in the world that allows assisted death for non-residents. When I was talking earlier about MAID in Canada, in order to qualify, you have to be a Canadian resident. Whereas Switzerland allows people from other countries to come for a medically assisted death. If someone's considering an assisted death in Switzerland, they should make sure they understand what their options are in Canada. Dying with Dignity has a web page to help people navigate the process, and they will also help people find the doctors and nurses to do the 2 assessments, if that's helpful, and provide witnesses if that's helpful as well. Dying with Dignity is not affiliated with any of the death clinics in Switzerland. Another option at end of life is palliative sedation. It does not hasten death, but it provides comfort in the final stages of life. In end-of-life situations where pain and other intolerable symptoms are constant and all other options have failed, the doctor may suggest palliative sedation. Intolerable symptoms can include pain, nausea, coughing, and shortness of breath. Palliative sedation lowers the level of consciousness to relieve intolerable symptoms, and it can never be implemented against someone's will. It can only be used after consent from the patient or their substitute decision maker. And I just threw in the term substitute decision maker there. I'll talk a little bit more about that, but you've obviously heard about it if you listen to the advanced care planning presentation. Another option here, CPR stands for cardiopulmonary resuscitation. It's a medical procedure designed to maintain blood circulation if someone's heart suddenly stops. It can involve manual chest compressions, or it can involve electric shock paddles. In Hollywood movies, people have a heart attack, they get CPR, and they live happily ever after. However, for frail seniors, the reality is often quite different. Even if the heart is restarted, the damage from the heart attack can be significant, and the damage from the chest compressions can be significant as well. So both of those can significantly reduce someone's quality of life after CPR. And that means it's important to think ahead about whether you want CPR, and if you don't, then the process is to work with your doctor to have a do not resuscitate order put on your medical chart and to have one clearly visible where you live. Because if the first responders, if the ambulance crew or the firemen come in and they take a quick look and they see a do not resuscitate order, they won't resuscitate you. But if they take a quick look and they don't see it, they're obligated to start to resuscitate you right away. So I'm going to change gears here a little bit. We've talked about the top section of this roadmap, and I'm going to talk a little bit about advanced care planning. If you talk to an emergency room doctor or nurse, they will tell you stories of where a patient has been brought in, the patient can't speak for themselves, and the doctors and nurses look to the family members for consent to perform medical procedures, and the family members are like deer in the headlights. They have no idea what the patient would have wanted or not wanted, and trying to get consensus in the family, amongst the family members standing there in the hospital, is just enormously difficult. Advanced care planning is the process through which people consider and discuss what's important to them in terms of their wishes for healthcare treatment and end of life. It involves choosing who they would like to speak for them if they can't speak for themselves. That's called their substitute decision maker. It involves documenting and sharing their wishes. So it's often helpful to write them down. It's certainly important that they talk to their substitute decision maker, their family members, their medical care team, so that people understand what their end-of-life wishes are, what medical procedures they think they would like to receive, which ones they don't, some idea as to what quality of life means for them. And then if their substitute decision maker is faced with a decision, they can go, well, you know, that medical procedure will maintain the quality of life, and that's important to this person, or that medical procedure will take away that quality of life, and they've told me that's a hard line, and so that gives the substitute decision maker a very strong basis on which to make decisions. Revisiting. This is not one and done, so it's something that people need to think about, talk about regularly, and revisit. You know, often it's important that they get to a christening or a wedding, but after that, their priorities change again. So people's priorities change, and they need to share that. In Hollywood movies, there are living wills. Here in Ontario, the law does not recognize living wills. Doctors and nurses need consent from the patient or from their substitute decision maker in order to perform medical procedures. If the patient is not capable, then the doctors and nurses look to the substitute decision maker. For people that have been through their advanced care planning process, it means that their substitute decision maker has a much better idea of what decisions the patient would like to be made, to have made on their behalf. It also helps the other family members understand those decisions. So the best time to think about end-of-life care options is when you're well and able. Some people describe advanced care planning as a gift that an individual can give to their family. Because if an individual is clear about their end-of-life wishes and what medical treatments they would like and which ones they would not, it can often remove a lot of stress and strife in the family. Here's an example of the complexity and the subtlety of the process. There was a man who had 2 daughters, and he had very firm ideas about what end-of-life care he wanted and what he did not. And he talked to his daughter about that, and he gave her his power of attorney for personal care. She became his substitute decision maker. And when the time came, he couldn't speak for himself, and the daughter gave the medical team direction that was consistent with his wishes, and he died. And at that point, the second daughter turned to the first daughter and said, "You just killed my father." So, you know, the man in question had done a lot of things right, but he hadn't talked to both daughters about what his wishes were. And that came as a complete surprise to the second daughter. And she didn't understand that the first daughter was really acting on her father's wishes. So in today's world where medical advances have so radically changed death and dying, I hope this presentation has given you an overview of end-of-life options. And with that, I would like to open up the question and answer and invite Barbara Bresver to take over.
Okay. I'm here and I'm trying to get on the video.
Your video was on, Barbara.
It's on?
Oh,
Okay.
now it's off.
All right.
It was on, right? Now it's
There.
on. Yes.
Okay. Great. And I'm on the speaker mode?
Yes, we can hear you. Yes.
No, I mean, I'm visible to everybody because I'm not on mine. That's
Yes,
okay.
we can see you.
All right. So each time I hear Peter, it underscores again how important the advanced care planning is, and underscores how important it is for us all to be aware of the options to consider for end of life. We don't typically want to think about it. There's an approach avoidance. And I think, as I mentioned last week, every time I do an advanced care workshop, I ask people how much of them want to be there and how much of them would like to be anywhere else. The other thing I want to mention before we ask for questions is that the word gift that Peter mentioned is a really, really accurate word. People often tell me that they are so relieved after becoming familiar with all this information, and they make some choices. They clarify their wishes, they make their choices with the understanding that as life happens and situations change, we can always modify what we've done. But this is an important starting point. So, are there any questions that you can give to me to answer?
Yes, so there's a couple of questions actually on the Q&A box. I can either read them out loud to you, or do you have access to the Q&A box, Barbara?
I'd prefer if you read them to me.
So the first one is, what is the focus of palliative care in long-term care?
The focus of palliative care, if you're in long-term care and you request palliative, it is, as Peter says, it does not prolong life. It doesn't hasten death. The main goal is to keep you as comfortable as possible. And these doctors, one of their main skills is pain management. And that is one of the biggest fears that people have as they near the end of their life. They want to be pain free. And so that's what the palliative care people do: comfort, pain free, respect. They look after all your needs, and they will be willing to discuss personal issues. They will be willing to help you and your family navigate the difficult parts near the end. And as Peter said, this can be done in a hospice. It can be done at home through the Timmy Latner Center group in Toronto. Once you connect with them, they will send a palliative team who are available to you and your family at all times, if in fact you want to stay there. So it's respect, dignity, care, managing pain till the end.
Great, thank you. The next question. I am in BC, but interested to know more about medical assistance in dying and how to start the conversation with the family member in care. Also, there's a follow-up question. Long-term care and end of life, how to ask for life to end in care home and not hospital.
Okay, that I'll answer the second first, and then I'll probably have to have you repeat the first one. Um, uh, in long-term care, in a nursing home, you have to be aware that some organizations will not honor a request for MAID, even though they are required by law because of their religious beliefs, philosophy, etc. They will not do that. And there is legislation now that's dealing with that because sometimes people have been forced to transfer to another place. Typically, the conversations you start with a medical doctor or a social worker. The social workers are very familiar with the process. And in BC, the access to MAID and the whole end of life process is very, very well established. It's been the strongest, I think, across Canada for some time. The issue is you likely have to bring it up. There are some doctors who feel that they're not allowed to broach the subject of end of life, especially with MAID, unless the patient client brings it up. It's up to you to raise it. And be aware that there are many times that doctors or specialists or nurses may say, oh, no, no, it's way too early to think that now, or why would you want to do that? It's not the time. If this is something you want to clarify and put in place as best you can in light of the current legislation, keep asking for clarification and an opportunity for a conversation. There is a, I have trouble with acronyms, the CAMAP, the Canadian Association for MAID Assessors and Providers, is across Canada, and you can access them, and they will provide you with someone to explain the process and begin an assessment. And if you qualify, if you meet all the criteria, and it is not a slippery slope, it is very, very well defined, then they will walk with you through the process and help you decide if that in fact is what you want, and if you want it, when and how and where. Okay, so I think I answered the second question. I'm not sure what the first question was.
I think I will combine the first question with another question that's sort of the same lines. So the first
Okay.
question was, I am in BC, but interested to know more about medical assistance in dying and how to start the conversation with the family member in care. And the other question is, not sure about BC, but does Ontario require advanced care plan to be done upon admission in long-term care? Is advanced care plan not supposed to be part of what the social worker is to conduct with the resident in long-term care?
The advanced care planning belongs to you. You should do it ASAP. It is honored. And in fact, I can't remember exactly where I saw this, but I know there are some places. I have a friend who recently went into a long term care facility, but for short term during rehab. And they asked upon her signing up if they could see her advanced care plan, her advanced directive, and her power of attorney for health care. So most of these places are fully aware of those, and they want to have those. It makes their job much easier, and most social workers are very, very familiar with it. In terms of getting more information about end of life options and MAID in particular, um, the Dying with Dignity chapters in BC are readily accessible. You can go on their websites and get the contact information. You can go on the national website, Dying with Dignity Canada, and it will give you all the forms and the information that is specific to each province. Some of the terms are different. Some of the ages for subject to decision makers are different, but you should have no difficulty at all getting more information from Dying with Dignity in BC. They're very, very active, and there are, as I said, there are chapters in different parts. Okay, is there something I missed in that combo of
No,
questions?
I think that was good.
Okay,
We're gonna go back to palliative care a little
okay.
bit. So this person is asking for patients in long-term care centers, how is palliative care the same or different as it is practiced in hospitals? I am thinking specifically about how DNR or sedation practice may be different. Any insights or examples would be most welcome. Thank you for the wonderful, informative presentation.
You're my pleasure. Um, palliative care has been around for a long time, and there are many, many proponents of it. And there are many, many assumptions that people make about it that are not true. Some people think palliative care is in the last few days of life. And in fact, once you get a diagnosis, and this can be in your 20s, 30s, whatever, um, you are essentially working with your doctors along using palliative care because it is addressing your situation. Uh, okay, I've just lost my train of thought. But palliative care, as I said, is it is something to consider and gain access to. And in a long-term care facility, depending on the section of it you're in, I mean, there are some that deal with Alzheimer's, dementia patients. There are some dealing with chronic illnesses. There are some that are dealing with natural aging and whatever deterioration comes along with that. But as you meet with the doctor in charge of your care, and the nurses and the nurse practitioners and the social workers, it is incumbent upon you when they say, we'll do this or we'll do that, for you to think about it and bring up other options, ask questions, um, make a decision not to follow what they recommend and to ask for something instead. It is your life. It is your treatment process. And one of the reasons that we do this type of outreach is to educate you and make you feel comfortable in deciding the quality and nature of the rest of your life. So we tend, especially those of us of a certain age, to put doctors and their recommendations as coming from God. And that's not the case. So, with education, with knowledge, especially about all the different options, you can say, I would prefer this. I do not want this. What can we do to do this, etc. So, you are your own advocate. And that's why it's so important in an advanced care plan or an advanced power of attorney for healthcare to name the substitute decision makers you want and familiarize them with all your wishes and choices so that they can communicate those same things to the medical staff. I just realized I missed something important. One of the questions was, how do I broach this subject with a member of my family? This can be difficult, it can be emotional, um, and it can be a wonderful opening of doors, or all of the above. Um, when someone is saying to you, I didn't think my life would be like this at the end, or I don't know how much more pain I can have, or um, I don't know why I'm still living. I had one relative who told me, I wake up every morning and I don't know whether to be happy or sad because their life was so limited now. Whenever anyone broaches it, even in like from a sideways, um, even sideways, you can say, I really understand that. Have you thought about the options? There are different things that you can do. There can be different places you can be. And if you qualify, there's a way of taking control and asking for medical assistance and dying. Have you ever thought of that? And that's the way to do it. There are hints. At the same time, there are people who will not talk about this and who believe strongly that, for better choice of words, if it's God's will, it's God's will. Um, in my personal experience, my mother had lymphoma that had recurred after chemotherapy, and the chemotherapy had caused some level of dementia. And she was clear that this was not the way she wanted to live. But this was before 2016 and MAID was legal. But she very often said, this is enough. I've had enough. And so many people said, there are things to look forward to and, et cetera, et cetera. And that's not what people want to hear. They don't need reassurance. They need a good ear. They need an active listener and at times help in linking them to somebody who can take the conversation further. Okay, so I hope that answered the question. In the ACP toolkit, there are also several suggestions on how to raise, even making an advanced care plan and talking about your wishes to others, not in a time of crisis, but now. So I just heard for example, I just heard a seminar on advanced care planning, and it's making me think about, or, you know, after going to a funeral and hearing about someone's life, saying, that really made me think, I do not want to end my life to end that way. I'd want to talk to you about that now. So we tend to avoid those things, and yet once that door is open, most people will walk through. If you find it difficult doing it on your own or with a family member, there are people who can help you manage that. Okay, next question.
Do people ever get transferred from long-term care facilities to hospice to receive palliative care?
I think that depends on the long-term care um, facility you're in. Um, that can be done. We need many, many more hospices, but if you would want to have your final days in a hospice, you work with a social worker or a family member and do that. The stay in hospices vary. It can be a few weeks, usually no longer than a couple of months, but that may vary as well. Um, and so doing your research beforehand, so that if you're thinking, if the time comes when I need a hospice, to research and decide which one would be preferable to you. Yes, it's, as we said before, this is helping for you to have control and a say over what happens when you fill in the advanced care plan um, and the advanced directive. There is a place where you say, you check off where your vision is for your end of life. I often say it's the 3 H's: home, hospice, or hospital. And if you're in the Toronto area, there is also Maid House, which is a facility where you can go. That's very home-like. You can have family there um, to have the actual procedure. When I do this with people, the vast majority say, I do not want to be in a hospital. Oh, and there are palliative care departments, or that's not the right word, in hospitals. Most have them, some formally, some not. Most people want home, with the proviso that it is not a burden um, to people, to the family, or if the other family members will feel comfortable afterwards, knowing that the person died at home. So it's something you really have to think about. And um, on these forms, you choose. My personal one is, I want to be have my end of life at home. Um, my family knows that. If for any reason it becomes impossible to do that, then my second choice is hospice. So you can be very, very specific. And if you pick a hospice, or you want to begin the MAID process, you can have a vision as well of what you want that final day, what the final hours to be. And it's not legally binding, but the people who care about you will likely make that happen. So again, you are not a passive person. You are not a victim. You have a say. And as you consider all the end of life options that Peter outlined and get more information, you will start to have a clearer vision of what has the most meaning and significance to you.
Thank you, Barbara. We have less than 10 minutes, so I'm going to try to group some of these questions together.
Sure.
So this one, so the person is saying, my mom is at end stage of Alzheimer's, 10 years in. She's been in long-term care for 8 years. However, she's still eating and drinking. Do we have any options for medical assistance in dying? I'm her substitute decision maker. We thought she was coming to the end. However, she seems to be doing a bit better again. In a chair of years now, can't do anything for herself, doesn't talk or know anyone. She was clear she didn't want this. However, I feel I'm not able to assist her.
Okay. That is a very emotional and challenging situation. My question is, does she have a power of attorney for healthcare and advance directive? If this hasn't been documented, then there's not much you can do. The situation is such that in my advance directive, I'm using myself as an example, and I can speak specifically to the issues you raised. One of the reasons I'm so involved in Dying with Dignity is that 6 people in our extended family have died of complications of Alzheimer's and deteriorated terribly. And we know that all of them would have been devastated, knowing how their end was. And so I am determined, as is my husband, my family, to ensure that people have a different ending for this horrible disease. Right now, advance requests are still under legislative scrutiny, unfortunately. But in my advanced directive power of attorney of healthcare, I have specifically said if I cannot identify anybody, if I cannot eat or feed myself, um, if I cannot da 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 da, then when MAID is legal, I request medical assistance in dying. The other thing that you can do ahead of time, and this does not apply to the situation you've just said, if there is nothing in writing, is that when any of us are diagnosed with early onset Alzheimer's or dementia, it is imperative to start working with a doctor then. And you can work with someone who is a MAID provider. The earlier that your case, your situation is documented, you meet with them regularly, you say, when I can't do this, I can't do this, I can't do this, I don't want to continue living. And yes, this can go on for 8 or 10 years, but if it is documented over time, then the doctor knows what your true wishes are. And that will meet the criteria for administration of the MAID process in some situations. Some providers are very sensitive to that. Some are so sensitive that when they are doing the final assessment, they will say, this person is more coherent and with it in the morning. Late afternoon, they are starting to hallucinate. So they only do the interviews in the morning. So Alzheimer's dementia is very, very difficult. It doesn't rule out MAID. It doesn't guarantee MAID. Often there is a comorbid situation, say diabetes or cancer that may qualify for MAID. But the situation you're in now, unless it's been documented and followed through by a practitioner, I'm afraid you have some more time available to you under these unfortunate situations. And again, that underscores again and again how important it is for you to be aware and talk to your family and your doctors and your specialists about what you want and document it so that people aren't in the position of the person who just asked me that question. That was a long roundabout answer. I'm hoping I made it as clear as possible. There's no straightforward, easy answer uh, to that. I'm hoping there will be once the legislation is finalized.
We have less than 3 minutes, so I think I'm going to ask the last question, and then the questions that weren't answered, I can maybe send it to you, Barbara, via email so
Sure.
you can to them. But you talked a little bit about this, so I wanted to kind of go back on it. But does the power of attorney for care allow for substitution, this decision maker for all the end of life options?
Okay. The substitute decision maker cannot request made or any other um, uh, treatment or option unless it's stated. The substitute decision maker, in some ways, is a misnomer. Very rarely are they actually making decisions. Substitute decision makers are your mouthpiece. They're your voice when you cannot speak. But even if you've talked about wanting a certain option and it's not written down, um, you're the person who makes the choices. When you can't verbalize them, then the substitute decision maker does it. But they can't come up with options that you haven't considered before. Okay?
Great. Thank you very much, Barbara. Let me just turn this video on. Great. So there are still a few questions left, but because we don't have a lot of time, what I'm going to do is I'm going to send those questions to Barbara and she can answer it via email. And Barbara, if it's okay with you, I will share your email in the chat box so that maybe people could email you directly if they have any more questions.
I'd prefer if we did it through you. I'd be happy to
Sure.
answer and send them back.
Great. So if anybody have any more questions or would like a follow-up, you have my email. Actually, I will rewrite it here. You can send it to me and I will forward it to Barbara, and I will also send the link to this recording once it is available on our YouTube account. So Barbara and Peter, do you have any closing remarks that you would like to say?
No, thank you for the questions. I hope I answered them. Sometimes I have a lot of information, and I can't get it all out. But again, if you go to the Dine with Dignity website, there's a lot of information. There are videos that people have done who have walk through the situations themselves or with others. So that's a wonderful place to educate yourself. I hope this has been helpful. Peter?
Thanks for the opportunity to speak with everybody. Really appreciate it. Thank you.
Mm-hmm.
Great. Thank you very much once again to Dying with Dignity and our guest speakers, Peter and Barbara, for this wonderful webinar. And thank you so much, everyone, for being present and interactive today. And like I mentioned, the link and the resources will be sent to you once they are uploaded. So thank you so much. Please join us at our final event next Wednesday. And if you have any questions, comments, concern, please feel free to message me directly. So thank you and have a lovely rest of the